I wanted to address a disease called Kawasaki's disease. Another name for it is mucocutaneous lymph node syndrome. And I think mucocutaneous lymph node syndrome may be a more apt term than Kawasaki's because it really describes some of the pathology associated with the syndrome. For example, the mucocutaneous, specifically the eyes of this baby here, as well as the oral pharynx here, is going to show some redness, inflammation, and um, other markers that are more characteristics of the disease. And also, it's kind of hard to see in this picture, but lymph node is usually associated with it as well, wherein you have swollen uh, adenopathy that's can be seen in these children. So let's get started talking about this disease a little bit more. So Kawasaki's disease, like I said, it's a mucocutaneous lymph node syndrome, and here is basically
Need to remember for Kawasaki disease is the crash mnemonic as well as the burn mnemonic. We'll discuss the burn later on, but specifically C stands for conjunctivitis, which is usually bilateral conjunctivitis and is non-exudative. Usually don't have any discharge associated with it. The R refers to a rash that's usually on the trunk of the baby, but can involve the extremities such as the hands and the soles of the foot. And it's usually a desquamating rash where you have peeling away of the skin. The A represents adenopathy, which is usually on one side and greater than 1.5 centimeters. The S is referring to the strawberry tongue that's associated with it. Remember that strawberry tongue can be associated with strep infections with scarlet fever. But it's not just the strawberry tongue. You can see the lips are affected, and the oral pharynx itself can be more erythematous, and you can have other findings as well in the mucocutaneous regions there. The H is the hands, which have edema as well as a crash portion of a crash burn mnemonic. I would say that the B portion, the burn portion, is really the significant part. More specifically, the fact that you have burn and you have a fever that has to last more than 5 days. That's really how you get these Kawasaki questions right. On a question stem, if you have a pediatric patient that's like in the range of less than 5 years of age and they have a fever and it lasts more than 5 days, it should be you should be on the alert for really the diagnosis of Kawasaki. Now, I put this in to really emphasize this idea, and this is really how you're going to get any of the questions right. It's not really a hard concept. If you have a patient, specifically a pediatric patient, because Kawasaki is a pediatric disease, a fever for 5 days, and you have 4 out of the 5 symptoms, specifically you have conjunctivitis, you have a rash, you have adenopathy, and you have these um, put this in because of what's mentioned in Pathoma. Dr. Satar mentions necrotizing vasculitis, and Robbins also talks about necrotizing vasculitis. There isn't much you really have to know about this portion for even step one. I think Dr. Satar mentions it as just a small vessel, but it's actually small, medium, and large vessels affected. In pathology, you do classify the different pathologies based on which type of vessel is affected. For example, arteritis is more of a large vessel disease, and therefore you don't see the small vessels that are affected. But Kawasaki's, you do see small, medium, and large vessels being affected. And the small vessel being affected is critical because one of the sequelae that's associated with it is the coronary vessels are involved. And that's kind of the critical thing that you have to remember with regard to necrotizing vasculitis affecting the coronary vessels. Hint about the sequelae of coronary artery disease associated with Kawasaki disease more so than anything on rounds with your attending, and basically that you don't see a pediatric patient presenting with a heart attack. You don't see a 5-year-old that has a troponin that's going to be elevated, or a CKMB that's elevated, or any other markers that you can kind of use as a marker of muscle damage and necrosis of the cardiac myocyte. So clearly, the only disease that's going to have this type of presentation would be your Kawasaki disease. And that's why it's really critical to understand that vasculitis of the coronary vessels leading to a myocardial infarction in a child is what you're really trying to prevent. And that's oftentimes this is the only disease where you would give a pediatric patient with a fever aspirin, because what you're trying to prevent is this myocardial infarction. That's oftentimes the pimp question that's asked of many medical students. One of the ways whether you have vasculitis that's affecting the coronary vessels in Kawasaki disease is to do an echocardiogram, which is basically you place the ultrasound probe on top of the pediatric patient, and you can see whether you have any dilatation of the coronary arteries. And the reason for this, of course, is ultrasound does not involve any radiation to the child, and that's ideal. The other test that you can do is an angiography. Essentially, it's more of an invasive procedure and it involves x-rays. So you're going to do either through the radial artery or the femoral artery. You're going to gain access to the vasculature of the pediatric patient, and they're going to inject dye in to see if there's any dilatation of the coronary vessels. And you can see the dye, which is going to be obviously fluorescent and emit radiation that can be detected via X-rays, and that is really what you're getting, which is an X-ray angiography. The key concept in terms of lab findings that you really have to understand is that this is essentially a systemic inflammatory reaction that's happening. What's really happening is that you're having a whole body reaction to this to this to this pediatric child. And so what you're going to see is that inflammatory markers such as CRP and ESR, which are not very specific but very sensitive for inflammatory process being elevated. And of course, since there is inflammation, you're going to have a leukocytosis. Your white cell count is going to go up, and then you're also going to have a left shift. That means your neutrophils, you're going to have a lot more of your immature neutrophils that are going to go up. So oftentimes you might be given a white blood cell differential, and you'll see that the leukocytes are elevated with your neutrophils being elevated as well. And usually during acute phase inflammatory reaction, you'll see thrombocytosis as well in the millions range actually. So those are some of the key lab findings. The key thing you want to keep in mind is systemic inflammation that's happening. In terms of treatment, and this is really the key thing that many examiners as well as PIMP questions try to go after. The key treatment is to give aspirin as well as immunoglobulins IVIG to the child. And this really reduces the thrombosis that can lead to the myocardial infarction. Now, we're taught that aspirin is a no-no for any pediatric patient because of Ray's syndrome, which can have encephalitis as well as liver problems, as well as a whole slew of bad outcomes for the child if you give aspirin to a child that's suffering from a viral infection. Now, here is the only exception where you have a pediatric patient with a fever for more than 5 days and you're suspecting, based on your clinical acumen, that 4 out of the 5 symptoms are met. You can start the patient on aspirin and IVIG. There are secondary treatments such as TNF-alpha inhibitors and glucocorticoids, but they come second to aspirin. This is more for step 2. You might be asked about treatment for Kawasaki disease, and it's pretty easy. What you're really trying to do is, as I mentioned in the previous slide regarding the fact that this is an inflammatory condition, and there's potential for thrombosis to occur as well because of the fact that you have chronic inflammatory situation happening here. What you want to do is you want to treat them with aspirin. And the reason this is important is because you have a pediatric patient with a fever for more than 5 days. This is pretty much the only disease where you would give aspirin, because we all know that aspirin is a no-no with regards to Ray's syndrome, which can result in liver failure as well as encephalitis. So this is one of the few diseases where what you give aspirin to a child, including aspirin, you would give also IVIG, and both of these are preventing the myocardial infarction as well as the aneurysm. Second-line treatments are TNF-alpha inhibitors and glucocorticoids, but the primary treatment is IVIG and aspirin.